Can you all hear me well enough? All right. So I want to get started here. Thank you for waiting and for being patient. I know we were getting a little, starting a little late. But welcome to our panel discussion, From Call to Compassion, a multidisciplinary look at addiction intervention. I'm very happy to see all of you here. Thank you also to Troy Swanson and the library for providing the space for us. My name is Annie Rasmussen. I am the program coordinator of the Addiction Studies program. Some of you might have seen me around. Some of you I have in my classes. And we have a panel here of people from other backgrounds, professional backgrounds. Sometime in the spring, Michelle Skeltern and I, we got to talk about the importance of the collaboration between police and nursing and counselors out in the addictions treatment field. And a lot of people don't know what this actually looks like. And a lot of people don't know how we are actually trained and what we do with people. So we thought this could be a great opportunity for us to share with you how our disciplines intersect, how we collaborate, and how we hopefully also in the future can maybe even become more effective and helpful in our collaborations out there. So I have a few questions that I will be passing on to the panel here in just a little bit. But before we get started, I would ask the panel members to introduce themselves, and we'll move on from there. So yeah, let's see. You do probably have to scoot forward.
I'm Jacinda Ross. I'm one of the nursing faculty here.
Good morning. I'm Dave Swanson. I'm a licensed clinical social worker and a certified alcohol drug counselor and a proud alumnus of this college. Thank you for having me.
Hi, my name is Joe Carlson. I'm a police officer. I've been a police officer within Cook County for over 20 years. I'm currently with the city of Palos Heights, and I'm also a licensed social worker. So we work to integrate social work concepts as well as joining people with area resources while we're on calls for service.
All right. Well, thank you, everyone. And let's get started. So the first question I have for the panel here is, what does addiction intervention look like in your profession or field? So it can be sort of like a little bit of a flowing conversation, but otherwise I would like for each of you to sort of like just describe a bit what it looks like for you, particularly out in the work, in real life sort of like scenarios.
So I have a master's in nursing education. I'm also in classes for my psychiatric nurse practitioner. So in nursing in general, on pretty much any floor you're on, you can encounter patients who have addiction. In my clinicals, I've been at Holy Cross Hospital, and we get a lot of referrals from the ER, patients that come in and they have to kind of figure out what's going on with them. And so there's a lot of substances, as I'm sure you know, and one of them that's becoming a big issue right now is cannabis. Everybody thinks it's not a big deal, but you can actually have psychosis. And if you go onto YouTube, you can find a lot of people who were previous users of cannabis who have said that, it's a big deal. And also just patients who have alcohol addiction. Sometimes it can start as early as age 8 when they have sips at like family parties and stuff, or parents who are alcoholics and things like that. And so we have to use good nursing assessment. I do some shifts on an inpatient older adult behavioral unit, and a patient came in and was admitted on a Friday, and I was working on a Sunday, and the nurse was a newer grad, and the patient, she was like, this is his history, and he drinks out every day. And I said, how much does he drink? And she's like, 1/5 of like hard liquor. And I was like, when was his last drink? Because like 48 hours is when the withdrawal really starts, and we were in that period, and so we had to transfer him off the unit. So I try to instill in the students that I teach here that you have to be really good at assessment and get a good history, because you can have a really interesting shift if you're not doing that. So
Yeah.
Okay, I'm going to say that for me, the interventions was when I left school and started, I worked with 100% court mandated clients. So I pretty much knew when we sat down what direction we were going to go, and it was quite challenging. However, today I work in a group private practice, so I don't necessarily see the majority of my clients with addiction. However, people come in and I find that for whatever reason they came in from, when I start to use the assessments and the screening tools, it starts to show up. But I think there's a stigma involved with people calling up and saying that they are looking for services, and they might say they're depressed or they're anxious. And then once they came in, things start to bubble up, and we start to ask questions like maybe, you know, when was your last drink, or what do you consider social drinking? I always remember that when your primary care says, do you drink? Yeah, socially. And then they just move on. So, you know, I feel that, you know, that's, maybe it's a lack of time for them or for training and not being disrespectful, but, you know, I think it gets overlooked. And one of the topics is I came in and I saw Annie and I saw the Cannabis Grow Bible right over here, one of the new books. And, you know, I'm not demonizing any substances, but I do find that because similar to alcohol being legal, readily available, it gets overlooked now. Where I have done screenings with younger people, and, you know, I don't want to ever forget that I used to be in those seats over there 10 years ago. So thank you for showing up. That when I ask them about substances, they don't even mention cannabis anymore as a substance because they don't consider it a substance at certain age levels. But so for myself, I am grateful that I have great partners and assets and resources for when people do come in and need a higher level of care, that I have places to reference them to. But once again, thanks for having me. Look forward to nothing but easy questions after this, please. Thank you.
All right, so our situation's a little bit more unique. When we start talking about meeting people where they're at, the police department has a unique opportunity to meet them in their living room at 3 a.m. And I think that's a perspective that needs to be shared. Additionally, when we get calls for service multiple times, whether any of us really want to or not, we generate a relationship there. So that also gives us a unique ability to provide insight if it's appropriate. So when we look at specific substances, we're looking at the total circumstances, maybe not necessarily the drug of choice, because people will shift, either access will change or whatever they're seeking will change. But the reasons for it most likely stay the same, and that's the root cause of what's driving them seeking something out. So for example, in the moment when we're working with somebody, let's say it's a quasi-criminal call, like a verbal domestic. Both parties live there. What are the police going to do? So that's kind of the issue. Nobody's going to jail for that because it's not illegal to argue with each other. However, this is an opportunity where an officer could provide some insight. I've been here 3 times this month. Is that working out for either one of you? You know, those types of things. Additionally, when we build these relationships, if we already have existing relationships with outside agencies that could provide them therapeutic services, and also understanding what their ability to pay or not pay for these services are. It's unhelpful to suggest somebody go to a private practice if they only have Medicaid and the private practice doesn't take it. So while we're there at 3 a.m. and then they call at 3 p.m., is that going to hurt our credibility with them when that practice says, sorry, I can't help you? So when we're working with these people, we need to understand the total circumstances. So, for example, I put together a couple questions that I ask people. Is the substance serving you? Now, this is not in the heat of the moment, but this is when we have that space of familiarity and understanding that we are here maybe 1, 2, 400 times. There was a call at a home, substance use related, We maxed out the CAD, our computer-assisted dispatch system, 399 calls there in under 4 years. Do you think we had a working relationship with that family? Absolutely. So in that space, these are some general questions that I will ask people. Is the substance serving you? What would you tell a friend if they were in this situation? And oftentimes it's a lot easier for them to discuss what it might look like for someone else. And then the question is, so now what does that look like for you? And then I also, again, if we have a history with them and maybe they've been working on some things and things aren't going quite to plan, you know, I might mention, I understand you had a plan, but how is that going? And then based on whatever that response is, I'll ask them, do you think it's time to revisit your strategy? Again, I'm non-judgmental, but it's helping them realize maybe this path is not going as I had initially intended, and maybe now is the time I will take you up on your offer of getting information for other outside agencies. So we are not people's therapists, but I think police departments and crisis intervention teams are in an absolutely unique position to truly be at someone's rock bottom. I know that's like a metaphor, and that can't be described except by that individual in that moment in time. But if there is somebody there in that moment to provide some of this thought-provoking, question, that's when true change could happen. So when we're on calls, all I ask as officers, ask themselves, is this a social service or substance use related call? And if so, just forward it to our team and we'll reach out to the people. One of the, like let's say it's a DUI, but the person had a really, really high blood alcohol content. 0.08 is the legal limit, but we encounter people that are 0.24, 0.3s. Now, not while driving, but while on a medical call, we did have somebody that was a 0.45. Scientifically, that should be impossible, yet here this person was. And in that moment, talking with them, they'd have to come down a little bit. You're not going to have a lucid conversation with somebody at that level. But later on, retrospectively, hey, you were at over a 0.4. You should be dead. How many times do you think that's going to happen, that you're going to come back from that? And that's when they might have the insight and want to change. So.
Thank you all for providing your brief introduction to what you do in the field. And I like also what you said, Officer Carlson, there on the questions that you would have for them. I see them too being asked again as they are like progressing through, can't speak for nursing, but at least like in counseling and therapy and the addiction treatment later on. We want to like really have them start reflecting on these kind of things. How is this working for you? Basically, right? So I don't know if you have any kind of like things to comment on each other right now for like a moment on what was said there, to link it sort of like in. I was thinking, so when you are meeting a person in crisis out there and they might need to go to the hospital, what is your first interaction with somebody coming in there? Could you just explain that, like just real brief, like how are you taking care of the person as they coming in, being under the influence and like kind of stabilizing them?
So, I mean, you kind of just have to be, direct. I kind of preface things by going, I'm not the drug police or the alcohol police. I don't really care what you're using, but we need to know what you're using because I did hospice for 10 years and we had a patient that had kidney cancer. And we were giving him a pretty hefty dose of Dilaudid and it wasn't touching him. And so then the next thing we say is, do you have a history of substance abuse? Well, he was addicted to heroin. So we had to call the provider and up his dose because he needed more medication. But we also have to kind of always be vigilant because I had a patient who had had surgery and his buddies came in and I walked in and I was like, what is that smell? he had vodka in a thermos, and I go, well, you can't have pain medication now. So we have to kind of look at the other end of things once they're in our care, that they're not using stuff that's going to interact with the medications we're giving them. So you do have to be a detective, and it is kind of disheartening in nursing because you do see people who, like you said, with what they come in with, and they can be really affected by whatever they're doing. And you do all these things to get them better, you get them through withdrawal, and then the first thing they do when they leave is they start using the substance or alcohol again. And you just kind of have to be like, you know, they have to want to change. And so it does interlace with counseling. And you just keep doing your thing, and you treat them every time they come in because they're people and they need help. So.
Yeah. And I think I can just add to that too, that that's also where it can become super important that you follow up with the ones that you are referring, right? So you actually know that they have checked in at that other facility, that they're getting that continued care when they leave your facility, right? All right, thank you very much. So I want to move on to the next. How do you feel that you are being trained, your background, educational background, both for those of you who work here at Moraine or have been getting your education here at Moraine, but also like more broadly, how much of the training fit well with what you're actually doing out in the field? What does that look like? Do you feel well equipped when you get out of school?
Well, I think from my perspective, the question, you know, the police would be separate from, you know, the social work, yet intertwined. And the reason being, especially when we're looking at crisis intervention related calls and substance use, understanding how to approach people in a non-confrontational manner, or, you know, there's this term de-escalation. It's a nice word to throw around, but what does that actually look like on the street on a call for service? You have to have somebody actually understand how to apply those concepts in a dynamic, moving environment to come down to a better situation to have actual conversations. So when we're talking about, you know, training, sure, there's the police academy and they touch on some of these things, but overall, when we're working with people, everybody's life is different. Everyone's lived experience is different. And when we look at college classes and what's available, having a broad framework of understanding is what's going to help apply those concepts in those individualized situations. So on paper, the police department doesn't necessarily fit a lot of the conversation that we have today. However, when we put it in the context of, they have to realize that they are in the perfect spot to fit these conversations. And then you have an officer with some lived experience, with some more education in their background, and they have the ability to combine that through communication. That's when all of this comes in. You know, I think the representatives on this panel, we are the continuum of care, theoretically. So here's the inception point. We have the hospital at the intake point for detox and, you know, navigating, you know, substance centers, that sort of thing. And then we have the follow-up care for the private practice. And something else I just want to share, I found equal success helping families, not just addressing the person that is working through the substance, but also the families, and having them understand building and maintaining boundaries does not make them bad people. And they're not wrong for asking themselves, what can I or can I not live with? What is acceptable in my house? What is acceptable for me? And that's where having their own therapists, their own support systems, that's important too. It's not just the person, it's a whole dynamic.
Dave, do you want to go? Yeah.
Okay, I'm very grateful to have these two colleagues next to me who are, you know, on the front lines here. And I've been with Joel, correct? Joe on the advisory committee, and I understand that that triangle of, you know, they meet someone in the field and then they're at the hospital, and then, as you said, you know, later on, perhaps maybe I meet them, how there's like a liaison or a handoff or something like that, so that we all understand where this started and where we're trying to go. Some of the things that I think about, and the training that I'm going to just describe, is the fact that Annie did a very good job of, we had a textbook, but we did a lot of things that were like what I'm doing today at work, which I am so grateful for, okay? Where we had like perhaps a police report, not from Joe, but, you know, and we did a case history. And how do we handle this? Or we got the report from the nurse or something. And then we had to put all this stuff together, try to figure out a treatment plan, try to figure out a diagnosis, try to think about the family, you know, because that's part of your curriculum here, which I'm so glad that you brought that up. And then I have great lived experience with one of my former classmates here, where we would do role playing in class, where we would do the work that we're trying to train for. And Annie can probably attest to this. I can remember when Hillary, I didn't know whether she was still going to be my friend after we did role playing, because we tried to make it about as real as we could, you know, but that prepared us for things outside of school, beyond the textbook. And I'm not saying that textbooks are not a good tool, okay? But trying to do things like we were going to do in the future where we worked. And one of the things that I'm going to share is, I don't like to be told what to do. And what I try to work with clients, if they come in and I feel that there's something with substance, I'll use some of the assessments that I was trained on here. I might do 3 of them. And then I'll show them all 3 assessments and say, I just want to share with you what you've given me. I don't tell them. They told their own story. And I use more than one assessment for them to look at it and say, okay, where do we want to go from here? As Joe has said, what's working for you? And then also, as my other colleague here has talked about, which I learned about, I believe in one of Annie's classes, we're so focused on prescription drugs or illicit drugs that we miss the, well, yeah, I drink a bottle of NyQuil every night before I go to bed. But you never asked me about that. So these are the type of things that I realized that, you know, I would ask people, people would train me on the brown bag. Bring me everything you take in the brown bag, which might be Valorin tea or some type of Chinese herbs or something, because otherwise I missed those opportunities of what were presented here, when someone, you're going to try to help them and not realize what they already have in their body. So, thank you.
Can I just ask one quick question before we move on to Jacinda? You completed an internship in your program here as well. How do you feel like that was helping you too? Just a brief sharing of what that looks like from a student perspective.
Okay, yes, internships I feel very strongly about, because prior to this career I was in another discipline and we did apprenticeships. So I'm a great believer in going and working somewhere while you're in school to kind of get on-the-job training, learn from other people in the field, perhaps maybe even mentors, work with other people at the internship that might not go to school where you to go to school at, and learn about what textbooks they're using or what their curriculum is or different elements of that. But also the fact that we would come back to this, is it the practicum? And where we came in and like debriefed, where all of us that are in internships would come in and talk about how things are going, where we're at, and, you know, sharing with the instructors, and then, you know, hopefully building other places that we might find out about from other interns that we could add to our list, because that is a difficult thing. I'm not in Annie's position, but finding where to place people in the field, because things are dynamic and not everybody stays in business or the same leadership. So, but I am a big fan of the internships, because that is where you're trying to practice what you're learning in the classroom.
Thank you. Jacinda.
So for nursing, it's a little different. I'm in school for the 3rd time. I think I'm, you know, need to be checked myself sometimes. I thought I would never go back after my bachelor's, but for nursing, we do have clinicals for our students in like either an inpatient psychiatric unit, different areas. They have a class in first semester that's like an intro to like psych and med surg, and then in their fourth semester, they have a more in-depth class. And so in that class, they cover things like alcohol, opioids, cannabis, stimulants, hallucinogens, and sedatives. And stimulants is interesting because there's amphetamines, which are like used like for ADHD, like Adderall, and then there's methamphetamines, which is, you know, crack. So you have to look at their tox screen and see what they're on. Because I had a patient that his mom's like, he's on Adderall. I'm like, I get that, but his tox screen came back for methamphetamine. So you have to, again, you have to be really vigilant and look at that stuff. And I do tell my students, you have to look at your patient from the neck up. Like as nursing, I think we get so focused on trying to fix them or looking at their medical things that you forget that you have to, I said there's a patient attached to what you're taking care of. So if you talk to people long enough, eventually you're like, okay, that's what's going on with them. So I try to convey, like you said, like stories to my students, things that I've encountered, because I learn so much from the people that I work with. And then for like my psych and P classes, my preceptor is fantastic. You know, she's in Holy Cross Hospital, and I showed up for clinical the first day and she's like, go get a patient. I'm like, okay, like it's very hands-on. And for one of the days on campus, they showed us the movie Girl Interrupted. It's like Angelina Jolie and Brittany Murphy. And they had binders made up for all of the characters in the movie. And we had to pick a binder and see if we came up with the same diagnosis as the patient had in the movie. And I was excited because I did. So we do a lot of clinical hands-on experience with the patients to kind of, you know, see what's going on. And my preceptor sees about 18 patients a day. This semester, though, I'm focusing on the counseling side, so we have to do clinical sessions with the counselor. So we always tell patients from the psych and P perspective to go, are you in counseling? So now we get to see what the therapists do in their counseling sessions. So it's a very well-rounded experience. And so I think the students do feel very prepared to go take care of patients. And then they're still in a preceptorship when they graduate and they start taking care of patients. So we do make sure that they feel okay on their own.
So if I could ask you a question. You had made the comment about seeing what the therapists do. Could you expand on how that's helpful for nurses?
Yeah, that is an interesting question. There are so many different types of therapy. But as you had mentioned with your screenings, like we don't want to tell patients what to do or what we think that they should do. They have to kind of be steering the ship for their own lives. And so I think that's been very good to watch how they interact with clients and how they don't try to offer advice too early, because then that puts a responsibility on, you know, the person giving the therapy rather than on the client, because we want them to be able to manage their own lives after they're done with therapy. And so I think it's been very good to watch like real life sessions and know what we're sending them to. So it's been very helpful.
Yeah, and I just wanted to expand on that because what I really appreciate about the Moraine Valley curriculum is there is psychotherapies and, you know, psychological understandings, not just application of maybe a standardized screening form. Because the reality is much of these, much of what the people that we're going to work with are going through, there's a past. And either they're self-medicating because of maybe another underlying mental illness that has gone undiagnosed or underdiagnosed, or there's a trauma or some other history that they're running from, but they themselves don't realize it. So everyone in the system understanding what we are all trying to address, where that came from, helps us stay on our mission, I believe. And that's what I really appreciate about the Moraine Valley curriculum, is it incorporates the entire dynamic of that person's life cycle of use.
Thank you, Joe. Thank you for clarifying that, and I'm glad to hear that you see that reflected in our curriculum. I can also add just a brief personal note. So, because I do notice that, so we have the first responder type of intervention, right? And then the emergency hospital kind of like coming in mostly. And then we jump up to a representative for the kind of like the regular outpatient therapy, longer term, less crisis patient or client. And I myself have been working mostly in the levels between hospitalization and outpatient. So for those of you who are not familiar with that, that would be what we would call intensive outpatient programming and or partial hospitalization program. And then we also have the residential, where people go into substance use or mental health treatment for a month or longer typically. So there are many levels of care, and obviously depending on how severe the addiction is and how severe the mental health condition is, we would want to match that up with the level of intervention intensity that the client need, right? All right. Okay. So I think we'll did you have a comment or no? Okay. All right. So we are going to be moving on to just a broad question, I would say, and I would like to hear from the audience too on this. What direction do you see your field going in? Are there any particular challenges, any particular exciting news or developments in your field that you're seeing, and what also are you hoping for in the future that might come to be part of our work?
Well, I'll kick off. Who here has heard of 988? Okay, relatively low number, by the show of hands. So 988 it's a federal system that got put out to the states. It's a mental health or substance use warm line, essentially. Now, where I see a lot of this going is there's a space for 988 responders. So right now, today, especially here in the Palos area, you could call 988 from any phone. You're going to get connected to a broader call center. You're going to talk with them about whatever you have going on. They're going to give you generalized information. If that's still not helpful, they will transfer you to a local agency. And again, here, it's a work in progress in Illinois, because Illinois is always Illinois. However, here in the Palos area, we do have established working relationships with 2 local 988 providers. They will talk with you about local services, and this is where this comes in about where I see things going. They have crisis responders that will come and meet you where you are at. If that's your living room, if that's McDonald's, if that's the laundromat, these systems currently exist within this area right here, okay? Ideally, all counties in Illinois are going to have it, but as of now, that's not quite the case. And the reason why I bring that up is, in my opinion, much of these calls are not police matters. Now, we are fortunate with the city of Palos Heights where we have discretion for many things. So I don't necessarily have to take law enforcement action for a substance sitting in front of us. I'm not going to leave you with it, but I'm not required to arrest you for it. And I think that puts us in a different place than maybe some other agencies that have less discretion, let's say. Now, 988 responders, they don't fall into that. They're not law enforcement. So when you're calling and talking with these people, they can come out and provide some of that therapeutic application of conversation without the fear of the law enforcement. And that's an area that is expanding. So ideally, within 4 or 5 years, that's a whole new frontier and a whole new possibility of employment for maybe even many of you in this room. So I encourage you to do some research on that. So 2 of our largest providers in this area are Metropolitan Family Services and Trinity Services. So if you're curious, reach out to them and ask them about how their system works and what they do, because there's a number of agencies that do good work, but again, just looking at the Palos area, those are the 2 main providers.
Thank you, Joe.
And I think for nursing, it's important to like stay up to date with stuff. Like I'm a big nurse nerd. I listen to a lot of podcasts because I live in Aurora, so I drive a long time to get here all the time. And I was telling Annie that, no joke, I was getting ready to go to clinical, and the day before that, I was listening to, I think it was a Carlat Psychiatry report, and they talked about this new drug called Trank drug. And it's xylazine, which is a veterinary medication. It's also used to tranquilize elephants, and people are mixing it with fentanyl. So when patients come in, if you give them Narcan, it reverses the respiratory depression from the fentanyl, and they breathe again. But then they're still like not responsive because the xylazine is, they also call it a zombie drug. And so the next day at clinical, we went to do a consult on the medical floor, and this guy was like in his 40s, didn't really make sense, like his history, and he had these wounds on his leg, which it's an injectable drug and they get wounds. And I was like, I think he's on this drug. And I looked back through the history, and sure enough, he was. And so it was interesting to like put those together. Like, you have to be aware of the new stuff, and it's dangerous because a lot of people don't, like, the drug dealers aren't going to tell you, hey, by the way, we put xylazine in this. They just want to sell drugs. But you have to be, vigilant on your assessment. And I've also worked with nurses. I've caught 2 nurses in my 25 years of nursing who were diverting medication to themselves. And it took me a while because I was like, I've never even smoked weed. I have 4 kids and they don't believe me, but I'm like, I've never done anything. But like you watch people's behaviors, and you've got to like kind of put 2 and 2 together. And so I tell my students this all the time, like, you've got to not just come in and robotically do your job. Like, you've got to really focus on the patients, watch what's going on, listen to what they're doing. And I think it's an exciting area. I love nursing. I'm excited to go into psych nursing because my dad has bipolar 1, and I had a very colorful childhood. And I think people, though, with mental health diagnoses get misunderstood. They get misdiagnosed. A lot of people that are homeless have mental health issues, and I volunteered for a couple different homeless shelters in Seattle when I lived there. And so I just want to spread that, everybody deserves to be treated with respect and dignity. And we need to have a healthy respect for what's going on with them, because working on the psych unit, like in a month, 2 nurses got bit really bad. So like it can be dangerous, but it's also exciting when you do help somebody and they do get some help and they do change their lives and move on and have a different trajectory than they initially did. So that's why I love what I do.
Thank you for, yes, and yeah. And Dave?
Okay, we're talking about the future, or what things
Yeah,
were.
any trends or
Okay.
issues, challenges you're seeing, like, or good developments?
Okay, and I'm glad that Joe brought up the 988, because we think that everyone, knows 988. And I have also had clients come to me and say, 988 is shut down because of the government. Well, that's not true. And at least I know today it's not true. But, and I will share what Joe was talking about, where I have other clinicians that I work with, and I'm the person in our practice that does addictions. So it's always like, we have a guy for you. His name is Dave. He's over here, okay? But when they need to do something, they are trying to call me, like 911, where's a treatment center? And I've directed them, call 988. They go, it's not an emergency. And I go, it doesn't have to be. You can call 988 and with your client right there and talk to them about where can we get services. And they were unaware, and we're clinicians, remember? We need to ask questions too. But a couple of things that, I think about, because this isn't the only advisory committee that I serve on. How many people here have ever heard of AI? Okay? Yeah. I'm not saying that you need to be an expert in it, but I think that you should start to understand it a little bit, because I'm not advocating that people will be going to robots or avatars or whatever. But like, I had a bunch of clients come to me and say, hey, I got this notice that said you're using AI. I'm like, how many people in here have ever heard of Grammarly? Okay, yeah, I use Grammarly to write papers. That's what I use in my progress notes, okay? But it's considered kind of AI, so we have to tell people. We're not diagnosing you with it. We're not recording you or whatever, but AI, I heard the other day someone said that AI is like the Wright brothers that created flight. compared to the space shuttle. We're at the beginning, okay? It's not going away. It's just something that I think you should look into and have some knowledge of. And the other thing is too, like, when I'm sitting here with my addictions hat on, the things that I think about that I wasn't prepared for, and this is no disrespect to Annie, people that came in with pornography addiction, okay? Shopping addictions, okay, process addictions, hoarding addictions. They kind of, you know, substances are always in the bright lights, okay? But those were the ones that I was like, oh, okay, what about video gaming, okay? It's not in the DSM, but if someone has a urine bag hooked up to them because they can't stop playing a video game, I think that we need to look into what's going on with their life. But I also think that, you know, going back to what's been said today is, you know, and I'll put my social work hat back on, you know, the biopsychosocial, looking at what's going on with the nurse, how did they get here or whatever, the social aspect, maybe that's why the reason that they're here. I have clients that come in and then they'll say, oh yeah, like 10 years ago I got a DUI. Oh, really? You know, that didn't come up before. You know, these type of things start to bubble out, okay? And then going back to who are you spending time with? And I'll go back to what, you know, Joe, I found that generally is not a good term. Many times trauma is in the background and people are trying to numb themselves out of this trauma, okay? And one of the things that we were trained for, you know, in Annie's classes, we got very comfortable with saying, have you ever thought about taking your life by suicide today? We got that rolled off our tongue. We did that constantly because we want to be able to say it to people and go, have you ever thought about taking your life by suicide? No, it rolled off all the time. And I ask all my clients that question, and I say, you're not being singled out, you're not special, but we need to ask these questions on a daily basis to all of our clients. So those are some of the things that I think about in the training, and you know, the things like, when Joe brought up the person who had the 0.45 alcohol, if someone has a gambling addiction, as long as they can keep clicking the mouse, it'll keep going. But if you do too much cocaine or you do too much alcohol or whatever, your body rebels and says, I'm passing out, or you start vomiting or whatever. But as long as the credit account keeps working, and then you start tapping into your family's credit, they're very, very bad outcomes, okay? But those are the type of things that I think aren't really shown a great light when we start talking about addictions. And they're out there too. And many times they are in conjunction with the substances, okay? So thank you for having me.
Do you have a question? That's why gambling is worse than gambling should be illegal. Is that what you're saying?
Well, I think that you bring up a good observation about people observing this is legal and this isn't. So maybe cocaine is illegal, so that's why I should stop it, but then I'm still chasing or escaping from whatever my history is. So now I'm going to go to something legal, which would be gambling, so you think it's better, you think it's safer. But in the end, it could be just as detrimental as the substance itself. And just to touch on the suicidality point that was brought up, you know, the only person uncomfortable with that question is you. Because if a person has truly considered it, you crossing that bridge and asking that, in my personal experience, can be a huge weight off their shoulders. Off the top of my head, I have no idea how many suicidal ideology calls I've been on, in the multi-hundreds, I'm sure. At this point, our crisis intervention team has worked with almost 1,000 families, and suicidal ideology is up there on the number of things. So your kind of homework today is to ask yourself, how would I ask that? What way would I be comfortable asking that? And the message is finality of life. So it could be very abrupt. Have you considered completing suicide? It could also be, have you thought about ending your life? Or maybe a little bit more subtle, but definitely has to have the tone of finality. Something simple like, do you think the world would be better off without you? And have you taken steps to make that happen? Have you thought about making that happen? And again, there's no right or wrong way to cross this bridge, but if you're picking up a vibe, there's a reason why you're picking up on it. And leaning in on that could be very helpful for the person that you're talking with. But it's finality of life. It's not ending hurt because they're considering ending their life because of the hurt.
And I forgot to mention, when I've asked patients, are you thinking of harming yourself or someone else? And they're like, that's against my religion. I'm like, but they didn't answer the question. So that you kind of have to find different ways to ask stuff. Another thing is that we can't forget our older population. Just because somebody is 65 doesn't mean they're not an alcoholic, doesn't mean they still don't use drugs, still doesn't mean they don't want to commit suicide. That's actually the highest population that tries to commit suicide, and I didn't know that a while ago. Like, as a new nurse, I look back as a new nurse 25 years ago and what I've learned along the way. And so I try to keep that in front of my students and say, you can't assume. Like, we had a patient that was on hospice and had an order to have a shot of scotch every night. We'd mix it in with pudding, and we'd like, here's your butterscotch, she brought like a full bottle with a handle on it. And there's a lot that can get missed because you just think they're, cute old people, but we have to think that they're still human beings and they still have things going on. And some of them are very, very serious, and they've attempted suicide multiple times. And so we have to think, like, when we discharge them, what's going to happen? Like, are they safe to discharge? Are their families aware that they can still try this? So I'm just thankful that I've learned stuff all the time. And as a new nurse, like, I didn't know, and I will never stop learning. So it's good to keep yourself in that mind frame that you can always learn something. So.
Yeah.
Absolutely.
Real briefly, I'll share an example of what you just brought up. We had an older person. I believe she was mid to late 70s, and she had attempted suicide. And when I was following up with her, I asked her, what happened? What brought you to that moment? And in a nutshell, her narrative was loss of purpose. All her friends had passed away. Her husband had passed away. 2 of her children had passed away. One from an accident. One was, I believe, from a serious illness. And she had attempted to recreate a community. She had attempted to make friends. And she attributed it to, nobody wants to be friends with the old person. So hearing that, applying some of the psychological aspects, we were able to discuss purpose and what that might look like or lack thereof, and is there a benefit to maybe trying other ways to regain purpose. So it's not just friends. Friends is part of the dynamic, but the root issue is loss of purpose and loss of community. So we kind of spitballed some things that she could do. She went back to reviewing her work history and maybe some ways she could donate some time at various things. And then when I checked in with her about a week and a half, 2 weeks later, she was actually very excited and enthusiastic because everybody likes free. So when she reached out to some industries that she would be very helpful for, they were like, yeah, you just want to come just to come? Sure, show up on Tuesday. And it helped reignite that sense of purpose and belonging and community.
That's a good point. Thank you for sharing that, Joe. Yeah, it matters a lot that we feel like we contribute in some way, whether it's just like socially or like in a more productive, like tangible way. I can add to that I have also seen in the field, particularly during COVID, when people became more isolated, staying at home. I think there were statistics too that the alcohol sale went, skyrocketed. We actually did not hear so much about the opioid use because I think focus was on COVID and managing that, right? But we started seeing in the IOP and PHPs more people coming in, partly because they were retiring early because of COVID, and now they were home and they had no idea what to do with themselves. They lost that sense of purpose, and this was particularly also the little bit older guys that they found they found escape in the bottle, basically, and came in. So it's a real thing that even with younger people, it's hard to just identify a purpose, but it's really worth thinking about. We are, in our field, we always talk about breaking things down into manageable steps, and sometimes it's a matter of one day at a time, those kind of things, to make you feel like you're actually accomplishing your goals. However, having a sense of direction is also incredibly important. So you've got to have that longer sense of, why am I actually even doing this, right? To bring you on that path.
I wanted to add one more thing. Social media, I have a love-hate relationship with. I have 4 kids. My youngest is 17, my oldest is 29, and my 23-year-old daughter was saying something about she saw some lady talking about how she got hooked on, I think, Norco, because she said she had some dental procedure, and then the doctor just kept refilling the prescription for Norco, and I was like, but that's not going to happen. I said, yes, maybe, usually they give you 6 Norco now. When I was younger, they gave you 30. But I was like, no doctor is going to keep filling that prescription for a dental procedure. So I'm like, I think that people need to understand that people are sharing all kinds of stuff on social media, but a lot of it is not based in reality. She probably went to some friend down the street to get Norco. She probably went to buying it somewhere else that was not legal. But I think it's important to keep in mind, you've got to filter those social media posts. I see people all the time, I'm trying to, go through alcohol withdrawal, and they'll film themselves, and I'm like, it's when you see it, you're like, that's not real. What they're doing is just they're putting on a thing to get, money for it. But so anyway, just a little post on social media, it's annoying because people can get off on the wrong track and think that something is real, and that's not actually what happens. So.
That's a good point. Yeah. I think there was a question over here.
Hi. Okay. So I'm wondering about the 988 thing, because I'm surprised I've not heard of it. And then the fact that you said it was that they will do crisis intervention. So I'm just wondering, when you say that, because you said without the fear of the police, right? We have a lot of people that overdose, or just kids getting way too drunk, and then not wanting to call the cops but their friend's sitting here puking and they're scared and they don't know what to do. Are these things that when you say the 988, is that a situation in where these kids can call that instead of allowing something bad to happen to their friends? I'm just wondering, because I just really do not know anything about the 988 thing. So.
Sure. And, well, a couple things. One, that's why I share information on 988, because I think it hasn't been shared the way that it should be. Okay. Ideally, in a perfect world, that's going to change, but is the information a little stagnant right now in this state? It is. In other states, it's not. This one, it is. There's a number of reasons for that. When we start talking about possibility of overdose, be it alcohol or substance, that's a medical emergency. That needs to be addressed first. So the reality is, in that moment, legal consequences come second to saving someone's life. So even if somebody called 988, 988 is going to call 911 because they are not EMTs. They're not equipped for the life-saving stuff. There is some caveats in Illinois law. If there is an overdose situation and somebody's calling, where police criminal involvement, let's say, are as limited or restricted. So there's some caveats to that. But Illinois put that in because they didn't want people dying out of fear of getting arrested for some needles or a little bit of dope that's laying around. And I think Illinois was very forward-thinking in that. So when I'm talking about 988, it's not necessarily at the crisis level. It's the pre-crisis level. It's the, things are not going well, and I really don't know what to do about it. And right now, people call 911 because we're free and we answer the phone 24 hours a day. But depending on where you're at, they may not be the best equipped to give you the answers that help you find a new path. But 988 is also free and available 24 hours a day. So I would urge the advertisement of 988, and that's the reason why I brought it up. And also, too, as the information grows, as the training grows, as the responders for these 988 groups increase, that's going to be a more widely used alternative to a traditional 911.
Thank you, Joe. Any additional comments on this, or?
Okay, I just want to piggyback off of, I believe what Joe said. When you're asking someone about taking their life by suicide and that huge weight that comes off, I personally saw that because I'll ask clients that more than once, not just at the intake. And further down the road after maybe the 10th session, and I ask them and they say yes. And I'll say, and when did you first feel like that? Like a year ago. So they were not going to share it at the intake because they feared that I was going to pick up the red phone. Okay? So I try to take that fear away and ask multiple times and often. And I have a wristband on my wrist that says, it's okay not to be okay. And that's when people go, hey, how you doing? You go, I'm good. Well, your real friends will call bull, and they'll say, no, you're not okay. Let's talk about this, okay? And I will say this, and I'm going to speak for myself, not for Joe. Older white males, I don't want to put the number on it, but it's above 65, are the highest in the suicide death because of a word that Joe brought up. They lost their purpose. Because I'm going to say that for myself, when you meet men and you ask them, hey, how you doing? What's your name? Where do you work at? What do you do? You're defined by your occupation. And after you retire and you're no longer working, you start to think, I don't have a purpose anymore. I start to feel useless. Then I start to get depressed. Then I start to isolate. And none of these work out, okay? And I also share this because of the work that I've done also with people who are challenged with, being homeless, where people that I had met in an internship that said that when they worked downtown in the Chicago Tribune, then they retired from there, they used to call the fire department and say, we've got a floater. And the coworkers would say, oh, another homeless guy. You know what? No. Someone who is younger, very high educated, and very well paid, but they couldn't handle the social pressure of losing whatever you want to pick, okay? A job, a career, a degree, a relationship. The people that were, and I'm not trying to make slight of people that are living in certain areas of the city, they're in survival mode. You don't see that very often, and if you want to look at the statistics, please do. But I think that is what I believe came up today is purpose. When people lose a purpose, get on that, okay? And I'm grateful to hear about the thing about volunteering and having somebody do something and giving back. So I feel that when people do volunteer work, and I have seen people in court-mandated situations end up going back after they've finished their community service because they enjoy what they did. So, but thank you for the questions.
Yeah. I forgot to mention one more thing. My brother has a nonprofit art gallery in Indianapolis, and I got to meet this documentary producer named Davey Rothbard, and he made a documentary called 17 Blocks. So I think it's on Netflix, but it followed a family for 20 years, and the most dangerous neighborhood in our country is 17 blocks from our capital in Washington, and Washington, D.C., and it follows this family where the mom has drug abuse history, and by the end of the movie, she's like 65, and she currently still has struggles with addiction. And then one son was going to go to college, and the other son was in drugs and dealing, and the son who was supposed to go to college got killed. So it's a fascinating documentary, and it shows just how hard that struggle is to get away from it. And like you mentioned, like the coping skills, there's a lot of self-medication people do because they have some heavy stuff they're carrying around, and it just, it's so sad. I've listened to intakes before, and I'm just like, you don't even know what to say sometimes. And so people need help, and so it is just a cry for help, but it's so hard to get past that and just, they have a family, and she did have a lot of purpose, and she just could not get out of that. So, and it's kind of hard to watch a documentary because it's a very realistic, like they do not hold anything back. The family was like, we want you to follow us for real, and he did, so.
Thank you for sharing that, Jacinda. Yeah, so hopefully this discussion today has brought to light some of the issues that are out there and brought to you a better understanding of what's going on and what you can do, places that you can go to help yourself or a loved one, a friend. This is really a matter of getting first intervention right, getting over that first crisis, and getting them into a safe space where they can feel like that they trust enough to open up, to also be receptive of all of the other resources and services that are actually available, because that's what we all do down the line, provide people with these referrals and resources so that people can get back on track. I don't know, we have a minute or two for last question, if there's anyone who has a question as of now. Anyone? Yep, oh, there's a couple of questions, yep, awesome.
Would you agree with the statement that you can't help people who don't want to be helped?
So I think the person themselves needs to realize if they need help. And I know that's not exactly the answer for you, but speaking with somebody who I worked with pretty closely that worked at a center, they went through their own struggles and they went to rehab 9 times. And I asked a very similar question at one point to them. And their answer was, every time I went, I picked up something along the way until I finally had the pieces to complete my puzzle. So at its face, it's easy for us to dismiss, well, this person doesn't want help, so I'm not going to help them. But the reality in my experience is, even though you don't necessarily want it now, I'm going to share what I'm thinking is going on, and you'll probably take that away with you and maybe add it to your puzzle later on.
100%, I agree. Yeah, I think as far as nursing, the discharge is the most important aspect sometimes of our care. Education is so important, and I make a little novel when I discharge patients, no matter what they're there for, smoking cessation, whatever, because like you said, as long as they have information, they may go home and be like, maybe I'll actually read this time. You always want to have hope for them because they may not have any hope for themselves at that point, so.
Thank you, yeah, and there's one more. Good question.
Hi, I wanted to ask about the effects of long-term drug use on the mind. What are some of the symptoms that can occur because of that, even after they quit drugs? And I also wanted to ask Joe, because you mentioned you were an officer and a social worker. How do you de-escalate a situation when a person is on drugs and they might not understand what's going on and might have increased paranoia or just something going through their mind that's not reality?
Well, I appreciate the question. I think a couple things we need to take a look at is the number of substances that can cause intoxication and not kill you through the magic of chemistry is in the multi-hundreds. So the issue of what substance are they on and what does that look like? In my experience, I'm not in a hospital setting, but in my experience, that's almost unanswerable because there's new substances every day that we don't even have tests for to know they exist until all of a sudden there's 30 people that are on it. So the long-term effects of all these, that is a huge question, and I appreciate it. In terms of the de-escalation of the situation, we look at making the scene as safe as possible for everyone involved. And again, that is a very dynamic thing. Especially if we're dealing with somebody in a psychotic state. Ideally, we would like to limit the cause of their agitation, but again, if we believe there's a substance involved, we're also dealing with a potentially significantly altered mind. So, and that's what officers go through a week-long 40-hour training class for, on recognition and working through some of these things. So it's not a super simple answer, and I wish it was, but these are some of the challenges that we face. Is we don't know what people are on, we don't know their initial underlying history, but we do try and limit the cause of their paranoia, and then we work forward from there as best we can.
And I took a psychopharmacology class this summer, and I was shocked to learn that the length of a cigarette is on purpose. The amount of time it takes you to smoke a cigarette is how long it takes for the nicotine receptors to be satisfied. and there's like 20 cigarettes in a pack because in a 24-hour day, that's how many you can smoke. And I was like, it's like an uphill battle when like it's that specific in how they formulate this stuff. So, you know, I was just on a clinical call this morning for my class, and this person said she's overdosed 17 times in her life, and she's like 34. And so every single day is still a struggle for her not to return back to that. And so relapse is huge. And like alcohol, I think it's like 60 to 80% relapse rate the younger you are that you take. So again, if you are 8 and you take some sips here and there, or, you know, you start experimenting in high school, like it's so hard to keep out of that. And so, again, you know, you want to keep having hope for people, but it does start to like alter the way you approach life. So it's hard.
Thank you so much. Yeah. It's about time for us to wrap up. I want to make an announcement.
I think we had somebody in the back. Did you raise your hand up back there?
Oh, oh.
Okay.
Oh,
I just wanted to ask because, like, for all of you who work in the field, and I know that some of the work you do, it could become like very emotionally overwhelming and stressful. I know you mentioned someone in the past like just becoming very overwhelmed. I think you said a firefighter or the fire department. So, like, do you all have any tips for how you manage your own like mental health and well-being just dealing with this type of work?
Sure. Again, that's a pretty that's a significant question, right? Although a good one, because if everybody in this room is going to be in one of the helping professions, these are things that are going to occur to you. And something that I advocate for is the realization, having a conversation with yourself that is not, it's not selfish to care about yourself. It's selfish to only care about yourself. So when I'm talking with other officers about crisis intervention activities, I ask them, what have you done for yourself this week? Because it's very easy to go 1 week, 2 weeks, all of a sudden it's a year, and you haven't even gone to the bowling alley, and that used to be your favorite activity. So a very simple thing that I practice and I advocate for, there's some things that I enjoy. They don't take a lot of time, but I put them in my calendar. So then that way I look at my phone and I'm like, oh, that's right, I should be going to do this today. Or maybe I'll try and see what I like. For example, I discovered I like $5 movies. It doesn't matter what's playing, but my mind, it allows myself to disconnect from the world for those brief 2 hours. And I wouldn't have known that unless I just experimented to see what I like and I don't like. So I accidentally discovered that my own boundaries were I was forcing myself to be connected, which was not helping me reduce my stress. But my mind allowed myself to disconnect in a movie theater because it's socially unacceptable to be connected to the world. So try out those things and make sure you do stuff for yourself along the way.
thank you. Yes. Oh. Wait. Yeah.
Okay, great
We'll be-
question, and I'm going to say that before I
have to
met
wrap it up.
Annie, there was this other person named John DeGangi who was part of the addictions program. And I remember in our very first class, he shared with us that if you were thinking about doing this and being successful, then you also need to be in counseling. You need to unpack your stuff, okay? And I continue to stay connected in counseling. It might not be every week, but it reminds me what it's like to be the client. What is it like to be in the waiting room? Are they on time? Do they have good water? All of the things that come with it, okay? But I'm just saying, he shared with us, if you're going to be the tool, then you need to stay sharp. And there's one way to do it. It's an option. I don't tell anybody what to do, but it's a good option to think about.
And I
Thank
know
you.
we have to wrap up, but I tell my students, I'm the lead of our PEDS class, and I interweave self-care into my PowerPoints because you can burn yourself out before you even graduate. Therapy also is super helpful, but self-care is so important. If you do nothing for yourself, even if it's like watching a half hour of a TV show you like once a week, something that you have to look forward to will recharge you, and so.
Right, thank you, yeah, and I can say too, we teach it in our addiction studies classes too, because across the board, clearly this is something that we need to take care of. We gotta fill ourselves before we can help others, right? I want to make one brief announcement before we totally conclude. Next Tuesday from 11 till 1 over in the cafeteria S building, U building, we will have a wellness resource fair where you can come, just come by. There'll be plenty of organizations from the community with all sorts of resources that you can pick up and you can chat with them and you can take with you, okay? So I encourage you to come by there. All right, so thank you very much for this great panel, and thank you all for coming today. Tuesday, November 4th, Stronger You Wellness Fair. Yes, 11 till 1.